which is phenomenal. It's brilliant to see so many people albeit virtually. Today at lunchtime, we've got everything from chief nursing officers to students, from acute trusts, community trusts at a local, regional and national level. So it gives me great pleasure to welcome you all today. We've got a fantastic webinar lined up for you today. It's the second in our nurse-focused webinars as part of the hospital-only discharge collaborative that we've been running since the beginning of the year, and actually marks the end of our collaborative approach as we move into the winter months and a new support offer. So I'm going to quickly go over a bit of an introduction and then hand over to my colleagues who will lead us through the rest of the day. So why are we here, or why are we doing this collaborative approach offer? We were asked as ESIS to support some improvement work as part of the National Discharge Task Force, focusing on hospital-only discharge. We've run a series of events over the year focused on 4 main themes around ward and board rounds, frailty, workforce and supporting operational processes. At the end of today's presentation, we'll be sharing some links to all the resources that are accessible to everyone. You just need to register on our NHS Futures platform. If you have not already done so, we can put that in the chat. You just need to send us an email and we can log you on. One of the main things that we've focused on is the fact that discharge is everyone's business. So I'm a consultant gastroenterologist working in London, but actually I work part of a multi-professional team, and it's involving the multi-professional team and enables us to move patients through the system safely and provide high quality care. So today's presentations are going to feature a series of case studies and collaboratives that have been run by nursing colleagues, and I'm really looking forward to hearing the presentations, but also to the discussion. And please do put your thoughts and comments in the chat, and we'll answer as we go along and then bring you in towards the end. So I think it's enough from me, and I'm going to hand over to Hilary, I think, for the next step, if that's okay. Welcome, Hilary.
To myself, that's a good start. Hello everybody, thank you Andrew. My name's Hilary Garrett. I'm one of the Deputy Chief Nursing Officers working in Ruth May's team in NHS England, and I'm joined by Charlotte, who you'll hear from later, who is also a Deputy Chief Nursing Officer too. So yeah, great to see so many people from so many different professions on here. So this is our second webinar in the series. We held one a couple of weeks ago with the ESIS team, and prior to these webinars we did the nursing team CNO, we call ourselves, with ESIS, did a number of visits, and small number of visits to 2 major hospitals and 1 big system, and we were connecting with clinical staff there. We're having conversations with nurses, AHPs and doctors, and firstly we're acknowledging the pressures that people are under and how people feel to be in such a pressurised system, and we know that pressure continues. There's acknowledgement of that, but we're having conversations with frontline staff that went along the lines of, we know this is really busy and there's so much information coming out from the centre. By the centre, that could be, you know, regional teams or NHS England, and sometimes there's so much coming out and there's so many forms you have to fill in, it's hard to see the wood from the trees, in terms of, particularly in terms of personal impact. So we went out to these organisations and systems, and the last webinar we had, and we asked a few questions that focused on, you know, how does it feel, but how can you actually do things differently so you'd have a greater impact and do things in a way that give you greater control over your working day? And how can you still make powerful decisions as individuals, but more so as teams that will support patient flow? So one of the aims of this whole thing that we've been doing since the summer is actually reconnecting with the people that really matter here, and those are people who are looking after patients. Focusing on changing our narrative from this is really bad, and we're marching to the drum of performance. Some of it's about adapting our language around discharge, so we feel in more control, patients feel more in control, thinking about our own personal impact and making sure we make the decisions we are allowed to make each and every day in our clinical practice. If we could have the next slide, please, that would be great. So the last webinar, we asked some powerful questions, and one of the questions that we asked is, what's the one thing that we could help you with? And I won't go through all these, but I think one of the biggest things was leadership. Let's get our leadership back as clinical leaders. We are all highly trained, very powerful clinical leaders. Help us not to look up for solutions all the time, but to regain the power and control over our day-to-day work. And how do we stop seeking permission to do the right thing all the time? What permissions can we take? What's in our control? So, and a lot of that is about a flattened hierarchy. Working with the hierarchy you maybe perceive that's in your organisations, but work with them and really make it clear what professional decision making you can take. So we've been thinking about that, and I think today we've got a series of presentations that are being championed by our clinical nurse fellows, and these are clinical staff that have come into my team, and they're working on 4 areas here, which we'll present in a minute, about what more they have been doing with clinical staff that will really enhance the discharge processes and patient flow. So we've got 4 areas here that you will see, and we can go quickly on to the first presenters, which is Wendy and Andy, who are going to talk about their work in preventing acute physical deterioration. And this is a national quality improvement community collaborative programme that's been up and running for some months now. So over to you, Wendy and Andy. Thank you.
Thank you for the introduction, Hilary. Hopefully everyone can hear me because I've just turned my microphone on. Great. It's lovely to see all of you this afternoon, and thank you for the invitation to present this work. So just building on what Hilary's just said, linked to every good discharge is, of course, a good appropriate admission. And during my fellowship in Hilary's team, I was asked to focus on a piece of work around acute physical deterioration. Now, whilst I'm talking about adult community nursing, there is very similar work going on for children's services with the Academic Health Science Network. So with any piece of quality improvement work, we start with the research, don't we, to look at what the current situation is. So looking at some of the learning themes from physical deterioration for people at home, because there is an increasing number of people being looked after at home, increasingly complex care. And some of the learning themes that came out from acute physical deterioration and admissions were around education in community nursing, equipment availability, the use and the standardised use of an early warning score, continuity of care, and the information that we share between hospital and community, both at discharge but also on admission. Now, it's also important to look, and we did look at some of the areas where we've got excellent practice, where we have exemplar best practice case studies. So we wanted to bring all of that together across a national footing. Next slide, please. So we came together as a group. We started with community providers from across England, represented from each of the 7 regions, and we agreed an aim that actually we needed to scope and test the effectiveness and the reliability of the management of acute physical deterioration in a community setting. And we started a national community collaborative for quality improvement, which we launched in July, will run through to February, and we will evaluate our work. Next slide, please. So the methodology that we're using is based on quality improvement, and it's a simple plan, do, study, act. So each organisation that's involved in the community collaborative has identified aims and measures for local improvement related to deteriorating patients at home, and we feed that learning back into the collaborative. And the benefit of that, of course, is that we can share what's happening in Gloucester with what's happening in Essex very quickly. So some of the benefits from the collaborative are we've been able to co-design and co-produce and standardise some tools and frameworks and share them very quickly. So we have that spread and sustainability. And each area is going to measure the impact on patient outcomes, patient experience, processes and pathways, and the impact, of course, on the staff working in the community. Next slide, please. So some of the benefits from coming together as a national community collaborative, you'll see on the right hand side in the word cloud, people have found it very beneficial to come together for sharing and learning. And some of the tools and frameworks we've developed on the left hand side have helped local organisations identify their local aims and measures for improvement. And I've got Andy Cole with me today, who's going to talk about how that's impacted on him working in a local organisation in Derby. But the main benefit so far about coming together as a national community collaborative is this proverb in the bottom left-hand corner. If you want to go fast, go alone. If you want to go far, go together. So without further ado, I'm going to hand over now to Andy, who will tell you about the local context of the work. Thank you.
Thanks very much, Wendy. So I'm Andy, I'm the clinical lead for advanced practice in Derbyshire Community Health Services. We're a very large community health trust, employ about 4,000 staff and cover about 1,000 square miles. So I'm going to just give you an overview of a quality improvement project that we did in 2018 to 19. Thank goodness we did that, BC, because where would we be without that? So as you can see, we had a number of drivers to improving our recognition of deterioration, and our mortality review process was identifying some failures in care that could have contributed to avoidable death because our community staff were not always taking the opportunity to measure vital signs, and subsequently patients were being admitted to hospital being diagnosed with sepsis and unfortunately dying. Wendy mentioned access to clinical equipment in the community, and back in 2018 we were at a point when some of our community nurses and therapists were buying pulse oximeters on Amazon, so we wanted to stop that. We had already implemented an early warning scoring system in inpatient services, so we were familiar with the concept, and then we updated it to the News 2. And we embedded this project within a whole system-wide approach to improving the journey of patients with sepsis and the recognition. So there were a few barriers. The nursing teams were concerned that we were over-medicalising their visits, and my main concern was that we would be having junior staff phoning up GPs, reporting abnormal observations for people with chronic illnesses who constantly have a respiratory rate of over 24 and a pulse rate of 100. But fortunately, my fears weren't particularly met. Can I have the next slide, please? So we adopted a project management approach and assembled a project team with project initiation documents and a fairly specified scope with key deliverables. You can see the project aims in front of you, which really reflected the fact that we embedded this within improving care of recognition and treatment of sepsis. But we've kind of moved away from that, and we recognise that the emphasis is very much on recognising deterioration, escalating that where appropriate, and initiating alternative care pathways where escalation is not appropriate. Next slide, please. So in terms of what we managed to deliver, we implemented the News 2 with its escalation plans on our electronic patient record, which is called System 1. So we developed templates and electronic questionnaires. We also embedded the UK Sepsis Trust screening and action tool, and we distributed pulse oximeters, and we standardised all clinical equipment across the trust. We distributed that to about 1,500 members of our community teams. We made the Royal College of Physicians News 2 e-learning mandatory and added it to our ESR competencies, produced a policy, and our communications campaign, which was at the end of Community Week, coincided with the World Sepsis Day on September the 13th, unlucky for some, but lucky for me because I won a bake-off competition with my Guinness cake. So I was quite chuffed with that. Next slide, please. So in terms of our project outcomes, we've evaluated where we are, and actually we've got 3 different ways in which we've evaluated it. So we have an audit, we've got a quality assurance framework which involves visits and structured assessments, and then as part of this collaborative we had the opportunity to seek the staff's opinions, and what we found we were really pleased with. It all triangulated that we've got staff who are frequently undertaking observations from a very poor number of observations initially, appropriately escalating, better outcomes for patients. Staff are really confident in their abilities and in their training, and training compliance is really, really high. So taking part in this collaborative has really helped us to recognise and celebrate the value of our previous work and highlight additional areas of improvement. Next slide, please. And as a result of being part of the collaborative, we've identified that we need to increase our awareness of soft signs, provide better support to staff who are having to deal with deteriorating patients on their own, working in isolation in the community, and improve their awareness of our revised policy by producing a policy on a page. That's it from me.
Brilliant. Wendy and Andy, fantastic presentations. Well done. Any questions, can you post them on in the chat box, and we'll try and answer them as we go along in the chat box. Next project is improved urinary catheter care outcomes, and again a case for impact and change. Safiso, Tina and Charlotte, welcome, and over to you.
Hi everyone. I think we're starting with me. Hi, I'm Tina. I'm a regional delivery partner for urgent and emergency care in East of England. And as part of that role, I lead on the urgent community response implementation of the national standards and have regular conversations with community teams about their services in the community in that urgent community response arena. And we gather lots of soft intelligence. You know, we're not just interested in performance against national standards. We're interested in what it's actually like to deliver an urgent community response on the ground. And what a lot of our teams have been telling us is that urgent catheter care is a big demand on their workload. One of the biggest demands alongside end-of-life care in the community and wound management. And we did some community data deep dives, particularly with teams that are data rich, to look at the detail around that, and really started that conversation, particularly related to discharge, 100-day challenge, where anecdotally our teams are saying there are a lot more patients leaving hospital a lot earlier because of those discharge challenge initiatives, and a lot of those have got catheters and are being twocked in the community. And then we have our national team who are driving further winter preparedness and resilience, and particularly focused on what could be done in the community around emission avoidance and early supported discharge. Next slide, please. And we've got this growing body of evidence that about catheters and how they're used, particularly around catheterization of patients in hospital leading to severe deconditioning. I mean, I'm not going to go through all of the boxes because you're going to get these slides, but the body of evidence is almost overwhelming. And so I got together with the community nurse fellows and had a conversation about what can we do locally to look at improving catheter care outcomes for our patients based on this evidence and what they were telling us about their workload. Next slide, please. And we started to look at some of the national data. So the model hospital has got lots of information in it about different aspects of care, not just in the community, but around hospital care. But these slides are about the prescribing habits within primary care in communities. And we highlighted our East of England ICSs. So this is intermittent catheters per 100,000 of the population, and we can see that we've got some systems in a higher quartile. So this right-hand side This is where you don't want to be particularly. These are the highest incidents amongst all of the ICSs in the country. Next slide, please. And these are the indwelling catheters per 100,000 of the population. And again, one of our systems, or two of our systems, are in that highest quartile of incidents nationally. And really, this data is a conversation starter to start to help our organisations understand where they should start looking in terms of key lines of inquiry that's driving the demand for this a particular condition in the community, and catheter care in particular. Next slide, please. So this is lower urinary tract infection, antibiotic prescribing habits within communities. Next. And then we looked at A&E attendances for urinary tract infection and start to look at bringing some of this information together. We know what the prescribing of catheters is. We know what the prescribing of antibiotic is. This is what's happening as a result of that behaviour. And we've got one of our systems got the highest incidence of urinary tract infection turning up at A&E because of that. That's the predominant reason for their attendance at A&E. Next slide, please. And these are our readmission rates. So these are admission rates for urinary tract infections for the over 70s. So these are all the rate of admissions over time. So again, we've got Mid and South Essex in that top quartile. They've got the top number of people turning up at A&E with UTI, and they've got a highest rate of admissions too. Next slide, please. And these are our readmissions. So this might have a this might be an impact of how well we manage our UTIs and our catheters in the community. And we know that catheters aren't the only cause of a UTI, but they're one of the causes of it. And so this formed the basis of us wanting to start a conversation with our caring community who are looking after patients with catheters. And start that conversation around what we can do to improve those care outcomes. And I think now I'm passing over to Charlotte and Safiso.
Thank you, Tina. So I'm Charlotte. So next slide. Oh yeah, that's the slide. Thank you. So the purpose of we set up this regional catheter network group with the help of Tina and working alongside Tina. And the aims and the purpose of this group is most importantly, it's guided by our members. So it's listening to what's working well and what are their challenges. So during our focus group part, across hospital and community services, one theme that we found was that they didn't fully understand the scope of each of the services and how we can improve those communications across hospital and community services. We also wanted to promote patient and staff education, so linking with that, developing best practice, shared learning and improving patient experience. So Mid and South Essex recently presented to our group to showcase the quality improvement projects that they're implementing in a response to the improvements they need to make. And this was also in response to some serious incidents that had occurred following poor patient discharge outcomes. So they had different examples of work that they've done, and that included having a new post of a catheter care champion from Mid and South Essex, Joanne Hurrell, who's a specialist urology by background. So far they've introduced home care packs for wards, monthly MDTs involving both hospital and community providers to discuss their complex catheter patients, further development of community TWOC clinics, having that Houdini approach, which is very nurse-led, and working with urology ambulatory to avoid ED presentations of patients. So that's just one example of what Mid and South Essex are doing. This will support the overall network in the region to develop skills and competences, showcase those quality improvement and improve standards and guidelines and policies. Next slide, please. So Dr. Kathy Murphy is a nurse and a principal research fellow in the Bladder and Bowel Research Group at Southampton University. She's joined our group and recently presented, posing 2 questions that I want you to take away and think about today. How can we avoid catheter use and reduce catheter harms? Next slide, please. So what's next? So for myself and my colleagues at VISO as Community Nurse Fellows, we'll be continuing to engage and learn from the East of England region, their catheter network group. We want to look at the scale of what the problem is from a national perspective. You know, what does the data tell us? What best practice is already being evaluated and can be nationally adopted? We've already started to join up with national continence groups, so we don't need to reinvent the wheel, and we can learn from best practice and research that's already going on. Lastly, and probably most importantly for me, we need to hear the voice of the patient and tell their story. The impact of catheterisation on patients and carers is not to be underestimated and can have a negative impact on their quality of life and psychological health. So thank you for listening, and I just want to say thank you to the region and thank you to Tina for joining us today, and as well to our Regional Director of Nursing Geraldine Rogers and Chief Nurse Catherine Morgan. When you get the slide pack later, there's going to be a list of resources and references that you can utilise, but also we'd like to hear the areas of excellence that you guys are doing out there around urinary catheter care, you know, where you've avoided catheter use or reduced catheter harm. And Sophie, so my colleague, will put our email addresses in. So thank you very much.
Fabulous. We got Charlotte McCardle.
Yep. Thanks, Hilary. Good afternoon, everyone. I'm delighted to be here with you today and to see such a fabulous attendance at the webinar. And the work so far, the two that we've heard about are absolutely fantastic QI projects, and I'm sure it'll generate lots of questions and thoughts for us as we move through the presentations, and hopefully we can pick some up at the end. So I'm delighted now to be introducing the next project, which is the delegation of insulin administration for people with stable type 2 diabetes. And I think this is particularly nice because it's Queen's nurse presenting this particular project. And I'd like to now welcome Leslie Mills, who's a community nurse fellow and consultant nurse in diabetes, and Julie Dutton, district nursing team leader at Sheffield Teaching Hospitals, to present their work. Over to you,
Charlotte. And thank you, Hilary, both of you, for inviting us to do this. In the interest of time, I'll just give a little bit of a background of what the delegation of insulin framework is. So under the direction of the Chief Nursing Officer, the community nursing team within NHS England began developing a framework for healthcare support workers to administer insulin in the community settings. Exemplar sites were set up and identified, and Julie, my colleague who's on today, is from Sheffield, was one of those exemplar sites. And it was set up as a quality improvement methodology, and those sites built the framework for what was launched in 2020. So the delegation of insulin administration is underpinned by those 6 simple principles governing the delegation of this task from registered nurses. First of all, safety. So delegation will not happen if it's not safe according to an organisational risk. Patient or individual benefit, which is the goal of all the changes to the way of working, so that it continue to improve that quality of care and that support for those individuals. Supporting staff across social care and health, and that's that all change must empower staff across the sectors and respond to staff concerns. That it's voluntary and discretionary, so that delegation of that particular task at a system level, organisational or individual nurse level will remain voluntary and is subject to the discretion of the registered nurse based on the care plan of that recipient receiving that care, their wishes, the nurse's judgment, and the nurse's judgment on the ability of that healthcare worker to assume that new task. And finally, support of the support from regulators. So that's all these changes that have been agreed and they contributed to the programme development. So the NMC, the CQC, RCN, etc. And then training and support is in place at all levels, and those changes must be supported by adequate materials, advice to supporting the safe implementation at a local level. And all of these are being co-produced with clinicians and social care staff. Next slide, please. So for those of you who are not doing this already, why not? You need to, and we're here to help. But there is 5 simple steps, and that can be done at organisational level, system level, or regional level, and I've got experience in my secondment as a fellow of doing that across the country. So the first of all is decide by yourselves to roll out that delegation of insulin administration. Then download and adapt those key resources, and you'll find them on the link, and in the pack that you'll get, it's an extended slide set, so you'll get more information. There's also a QR code that will take you directly to the information as well. And within those resources, there's the national framework, there's a sample documentation for delegation of insulin administration, there's an organisational checklist, there's a competency framework and workbooks, and there's a health and care worker checklist, along with frequently asked questions, top tips, and examples of previous webinars where it goes through that information. Once you've downloaded all of that, then obviously training for them and mentorship, and there's e-learning for health, again another link where you can go on, and all that information is there for training and for competency sign off. And then it's about implementing that delegation of administration and monitoring, evaluating and recording the effectiveness of that work. And now I'm going to hand over to Julie, who was one of the exemplar sites who's got that proof of benefit for workforce, client and economic value. Thank you, Julie.
Hi, I'm Julie Dutton. I work for Sheffield Teaching Hospitals and I'm a nurse lead now currently for community nursing. We introduced the delegation of insulin to our support workers in 2018 as a city. It was rolled out. I was part of the pilot scheme that first introduced it in 2017. My team was originally chosen because of the increasing caseload and the increasing amount of patients that were needing assistance in administering their insulin. I was finding that I was really struggling to delegate work to my team because insulin seemed to be the predominant treatment that we were doing, and sometimes that took us right up to lunchtime. In a small team, it had a massive impact. So what I was finding is I was struggling to then delegate any unplanned visits to the qualified nurses because they were busy doing insulins. So before we started, it was important that all the diabetics on the caseload had been reviewed by a multidisciplinary approach by the team leader, the community matron and the diabetes specialist nurse. This ensured that the treatment was optimised and that they were stable. So part of our policy is that patients need to be stable before a task can be allocated basically to a support worker. Staff went through a robust training and competency package. This also enabled regular staff that they were then updated, so they knew about all the latest things that were happening within diabetes. And during that time, the team were averaging around 55 insulin visits a day, and we had generally tended to have about 8 staff on duty. So looking back at this slide that Leslie's produced, when we evaluated our pilot, it was apparent that the patient outcomes were really good. The feedback that we got, the patients felt happy with the care that they'd been given. So the process was based on a named nurse and patient basis, so that the support worker could only go to a named patient that had a consent form within the house that had given consent for that support worker to administer the insulin. The patients felt safe. They felt that they were listened to and they weren't rushed. They were able to sometimes offload to a support worker. They felt that they got a little bit more time to listen. They would recommend the service to family and friends. And they also felt that their insulin was administered in a timely way so that they could then get on and have the breakfast in a timely fashion. And that if there were any further issues throughout the day, that stopped that. And then the healthcare support workers, as part of the evaluation, they fed back and felt that it increased their motivation for coming to work. It felt that they felt useful. It boosted the confidence, but also reiterated that they could only work to their own competency and their own capabilities. They felt valued and supported, and they felt more of part of the team. Retention rates for support workers in Sheffield has remained stable. We've got a good retention rate, and it also enables the role to be more appealing when we're wanting to recruit new staff. The service benefited massively. It improved efficiency. It allowed me to delegate more appropriately. It improved skill mix throughout the team, not just for the support workers, but throughout the team with staff nurses. It kept everybody more updated. And what it did do is it allowed qualified staff to attend more complex unplanned visits. So it helped to try and avoid some avoidable hospital admissions because they were more reactive. It gave us a bit more flexibility within the team, and there were definite cost savings from what we'd done previously, and I think Leslie's got some figures.
Yeah, we did. Julie and I just did some quick figures, and I know I've put something at the bottom of that slide, but actually that's out of date now. So on Sheffield's figures alone, they're spending £1.23 million a year on purely giving that an insulin injection daily to the number of people they've got. If they delegated that to a healthcare support worker, band 3, that would cost them £217,000, which is a cost saving of over £1 million. Just in their 23% that they delegated last week, they saved over £6,000. So there's some amazing data there, and we're collecting more, but it shows how moving that skill mix, you're going to have those registered nurses focusing on the more complex individuals and really, you know, valuing your workforce and putting them in the right place at the right time. Thank you.
Thank you.
Thanks so much for that. Another really interesting discussion, and I can see it's generating some comments in the chat box. So does anybody have any particular questions that they want to ask just at this time on that specifically?
Charlotte, I think in the interest of time, we're going to have to move forward to
okay.
back to some questions later on, if that's okay. Perfect.
Okay, thanks so much. So the final presentation then is on staff safe transfer of care, collaborating work between hospital and community teams. And I'd like to now introduce Sarah Brownlow, Community Nurse Fellow, and Kim Crabtree, who's an ADN in Morecambe Bay, to talk about their work. Thank you.
Hi everyone, it's really lovely to be with you today. Thank you. So yeah, I've got that slide. So the background to this was very much I got asked at the beginning of year as a community nurse fellow to head into Morecambe Bay Hospital Trust just to support them a bit in terms of decision making around our big rising numbers from Omicron. And I met quite a lot of over a couple of months, met quite a lot of staff, both community staff and hospital staff. And I also made a friend in Kim who's going to talk today as well, which was lovely. And we came up with a bit of an idea, a bit of a suggestion between us, and when we were talking about transferring of patients, and so our work was born. So the safe transfer of care of patients between community hospitals, between hospital and community sites, we said was fundamental to ensure that high quality care is provided to patients. And by working together, hospital and community colleagues have that knowledge, insight and lived experience of patient transfer to create the right conditions for the high quality care. So our main premise was to create space to build relationships between colleagues working across different care settings. And it's working across the organisation. Staff can develop these relationships and use the initiative to support and improve that safe transfer of care between settings. And we're very much focused on transferring patients into the hospital environment and out of the hospital environment. So it was very much about looking at a two-way process. So our idea was that actually we got district nurses together, ward sisters together, team leaders, community and hospital therapy together to build relationships through a very specific set of activities. So I'll move on to the next slide, please. We went into this idea into the work with a number of aims, and that was about facilitating those conversations between hospital and community colleagues, building relationships, developing key mutual contacts, developing best practice guidance for both the hospital and community team, and to facilitate a shared understanding of individual challenges around the discharge process, but working together to solution build. And then key was to empower staff to implement small changes by working together between hospital and community staff and giving permission to create those conditions. So what we did, we had the launch event about 3 weeks ago. We started off in the summer with an anonymous survey across the hospital and community. And we asked things like what works well, what doesn't work well between both hospital transfer and community transfer. And then we asked if you could break the rules in service of a better experience for patients, what would you do? So we had 51 people at our launch event, and we used the survey feedback to give us a focus for the day. And then using a public narrative focus, we set the scenes about why we were doing that work. Next slide, please. So these were some of the findings in terms of the survey, and you can see that there are a number of people that don't feel that they have the right information to facilitate a safe transfer of care, and some people who don't even know who to go to. Next slide, please. So this was some of our survey feedback, and I'm not going to read it all, you'll get more information in the pack that comes out to you, but a lot of it was very much about that communication, that lack of understanding about what community do or hospital do, and there was very big differences between the areas. And actually somebody said, a lot of people said it was the ability to talk to somebody on the ward that made the difference, and the ability to talk to somebody in the community that made the big difference. Next slide, please. And this was very much about, when we asked about what rules would you break, to me, when I read those, none of those are rules that we would have. So it really demonstrated to us that actually if we could start getting people into the room talking with each other and spending time with each other and sharing their difficulties or things that go really well, then that would help us to develop those relationships. I'll jump on to the next slide. So we use this 4 nuggets exercise on our launch event in groups, and the groups were mixed groups of hospital staff and community staff, and we went through these 4 areas to guide the work that we were then moving on to develop in the future. So I'll ask for the next slide and I'll hand over to my colleague Kim.
Thanks, Sarah. So I think the key findings for the day, there was a lot of energy in the room, and they certainly echoed the recommendations of the Queen Nursing Institute's discharge planning report, in as much as the communication, the need for communication, collaboration and coordination were overwhelmingly the messages. Of course, you have some skeptics on the day, but really there was a genuine curiosity to understand each other's roles and the challenges that everybody faces on a day-to-day basis. There was an excitement about them being invited, and they felt truly valued for that. And very quickly throughout the morning, you could see them start to develop those crucial relationships that were going to be kind of the bedrock of what we were trying to do. We could see them swapping contact details, setting up Teams messaging channels so that they could keep in contact after the day. And I think the overwhelming message was that communication was the biggest challenge they had, trying to communicate with each other in a timely way on a daily basis. Next slide, please. So very quickly, there was a number of projects that we could really get to grips with, and hopefully we can start to do something over the next 3 months. We really need to improve the access and be able to communicate in a timely way with the right person in the right place. We think we can do that over the next 12 weeks. Crucially, we're going to need to make sure that teams have access to smartphones. In community, we've already rolled that out, but we need to look at that for our ward nurses and AHPs who are leading that shift. Those phones need to be pre-programmed with contact details so they can have that timely communication, and we need to set times where it's the most appropriate time to contact you. So some kind of operating procedure to kind of reinforce what we're trying to do. We also need to make sure that teams are dialed into MDTs appropriately. We know from a lot of the studies that have been done that often when an MDT is called, community often aren't included, and yet we have all that rich resource and information about how that patient functions at home. And hopefully that will improve the communications with the team, it'll improve staff satisfaction, there'll be joint decision making, and we'll start to build those relationships based on trust. And actually that's going to be the foundation for all the work that follows from this, and it will improve the outcomes for our patients. From a quality of information perspective, we already use the SBAR tool from community into hospital. We need to really refine how that is used and how speedily that's accessed by the receiving ward. But it does need a little bit of tweaking, details around housing and care concerns, and I think it's going to dovetail very much with some of the work we're doing around anticipatory care planning, so that on transfer into a ward environment, the ward staff will have that rich seam of knowledge around how that patient functions when they're in their home setting. We also want to try and implement that from hospital back out into community. Currently, we have a referral process. The jury's out as to how well that works, but if we could use the continuation of the SBAR sheet and just update that with timely communications around the hospital stay, that would add to that picture of that patient and that continuous process. Next slide, please. The other key consideration is around promoting self-care. So we talk a lot around self-management and self-care, and we use those terms interchangeably. They are different. So we have patients with long-term conditions who, to maintain their independence, actually self-administer, insulin being one of them. We know that when they go into hospital, often that's taken from them and their insulin is administered by one of the nurses on the ward. We know then when they transfer back out, they've lost their confidence and competence in doing that, and then we have to go and, over a period of days and weeks sometimes, reintroduce that so that they can do that for themselves. There are also those more short-term things following surgery, so Clexane, eye drops. There's a need for those patients to be taught before they come out into the home, and again that's around staff education and for them to truly understand the expectations when they get home, that you will be required to give your own Clexane. We're happy to go in and support you, but the understanding would be that you would be self-caring. So there are lots of opportunities, I think, for both ward staff and community staff to work together to promote self-care, both whilst they're at home and then when they get transferred into hospital. Next slide, please. So what's next? So we do really need to keep up the momentum for this. We're going to follow up with another workshop, this time virtual via MS Teams, to really truly understand what the biggest challenges are, some of the things that we really need to tackle, and to give them feedback on the previous workshop. And so there's an opportunity now that we can build that into our regular cycle of meetings and catch-ups, and I'm hoping that even when this piece of work comes to an end, we will have set the foundations for that to carry on and build on in the future. Thank you very much.
Wow, well, thank you. Oh, sorry, Charlotte, do you want to come?
No, I was just going to say, in the interest of time, I'm going to just say thanks so much to all four and hand over to Helen.
Oh, sorry, I was too keen. Well, thank you to all of the presenters. Like Charlotte's just said, it's really delightful having listened to all of your sort of improvement pieces and your journeys. And before we have got a little bit of time for question and answer, but just a comment really that somebody's made in the chat around how wonderful it is to see the amount of improvements and the amount of projects that's gone on during such a really difficult time across the NHS. So a really huge well done. It's really, from an improvement perspective, we love working with colleagues like you that are very, very data driven and really mindful of how you can measure and show your outcomes against patient care. So it's been really inspiring listening to all of you. I'm just going to say, really good in the chat room that you're all connecting with each other. So there's lots of information that's been requested. And just to reiterate to the audience, all of the resources that the speakers have shared with us will come out in quite an extended pack afterwards. And I know that there's been quite a nice responsive chat from each of the presenters as questions have come up, but there's just a couple just to come up, and then if there's anyone that wants to raise their hand and ask one of the presenters directly, then please do. We'll see. We've probably got about 4 or 5 minutes, but just on this last presentation, Tina's just asked whether or not community teams are alerted when a patient on their caseload gets admitted, and does that then trigger the hospital and start discharge planning immediately?
That's the million-dollar question.
Yeah.
It's the million-dollar question, to be fair. And I'm just trying to put something back in the chat. So it is something I'm keen to work up. Currently, we've got shared access to records, but our community staff would need to access Lorenzo because you don't always know that your patient's been admitted to hospital. So the simple answer is no, we don't have that well defined at the minute, but I think it's something that we really truly do need to work up, because it's a case of we have to find out and then we have to find out where the patient's gone to, and then we have to contact the ward. So I think that's something that we could fix quite easily with the infrastructure that we've got, but it just needs a bit of thinking space, I think.
Lovely, thank you. And just one that I picked up for Leslie, just around some, you may well have answered this already, the chat's moved a bit quick, but it's just around how did you find that all of your team were keen to be involved with the processes that you were using, keen to be involved in the delegation side of things?
So certainly in the providers and the organisations that I've supported in this role, there have been some that have been a little resistant or unsure, but then once 1 or 2 healthcare support workers come on board, they've then championed and it's actually shown some sort of, well, look at me, I'm, you know, I've got my own little caseload, and they flourished. And in fact, some of them have gone on now to do their training, their registered nurse training, which is wonderful. So that influence that they have over the teams is amazing. And I know Julie would probably say the same in regard to her team, because I think you had the similar situation with yours in the beginning, didn't you?
Yeah, I had a very keen healthcare. I actually inherited about 5 support workers when we had a merger of teams. So I used to struggle with delegation because I had a lot of support workers. But I had one that was really keen, one that wasn't so keen. But eventually, when the pilot finished, everybody was really keen about it, and that got spread throughout the city, really. So you only need one with massive enthusiasm, and then it pulls everybody through. And they can see the benefits, the patient benefits more than anything.
Yeah, that's fabulous. I definitely would agree with that. You just need one follower, 1 or 2, and then off you go. Your movement happens. Oh, sorry, someone's got their hand up. Who's that? Sharon, do you want to ask a question?
Yeah, it's just a quick one. And hi, Leslie. We chatted yesterday about the diabetes work that you've been doing, which is fantastic. And obviously somebody mentioned it in the chat box around the care sector and how insulin delegation is working there. And you obviously, we had a small example of it in Kent and Medway, and you mentioned some areas. But I just wondered, you know, in terms of how we support the care sector, and particularly in nursing homes and residential homes, how much work has been done on that, because trying to find good examples of that from a governance perspective as well is going to be key in supporting the care sector. I mean, especially through the winter months, we'd be really keen to really explore that.
Absolutely. And you know, again, there's amazing examples. For example, in Cumbria, they rolled this out during the height of COVID and lockdown because they knew, they could see it was the right thing to do. And so with the support, even virtually, they managed to roll that out in their care homes. So there's some great examples across the country, and that's what part of my work and the rest of the fellows' work is, to link those regions and those really great examples and best practice. And we'll develop some rapid reads. We want those examples from yourselves so we can share them.
Yeah, no, that'd be great. Thank you.
Thank you. There are still lots of conversations in the chat room, so thank you to all the speakers that are answering as they're going through. That's really, really helpful. And again, we really would encourage you to maintain the sort of connections that you've just found, and when the packs come out, please do ask the questions directly to the team. I think everyone's put their details in so that you can have those ongoing conversations. But unfortunately, we are going to draw to a little bit of a close now. And I'm going to just hand back over to Andrew to conclude the session. Thank you all.
Thanks, Helen, and thanks everyone again for the presentations, which have been fantastic. I was at the Royal College of Physicians last night, and we were talking about the importance of bringing back joy to the workplace and the importance of inspiring younger clinicians in particular and the next generation. And I think today's presentations have highlighted what happens when you put that into practice. I think there's a lot of talk at the moment about fixing problems. I'm personally not a great believer that the current challenges can be fixed per se, but I think what we've seen today is that by using an improvement approach, we can work differently, we can bring back improvement into the work that we do and provide high quality care. So thank you all for your case studies today, really were outstanding. And thank you also for responding to everyone's conversations and questions in the chat in a timely way. That is really appreciated. This is the close of our hospital only discharge collaborative approach. All our resources are available on the NHS Futures platform.